So we all know, I don't want to go into a lot of clinical details. So the standard of care for ovarian cancer has generally been primary debulking surgery, followed by post-op chemotherapy. Paclitaxel carboplatin has been the standard for many years. Versus you may give a primary chemotherapy followed by interval debulking surgery and later complete the chemotherapy. And the most important aim at the end of all this is you should try to get microscopic residual disease, because that is what determines if you have achieved a microscopic residual disease, you can improve the survival of these patients. Then, now what has changed over the last few years is you check for germline or somatic BRCA mutations or the HRD genes, and then you use a maintenance PARP inhibitor with or without bevacizumab. And this actually has made a little big difference in patients who are HRD or BRCA positive, where you have where you talk about 7-year, 8-year survivals and maybe probably cure also for this group of patients, especially in the advanced ovarian cancers. But this is okay in only about 50% of patients. In the rest 50% of patients who don't have HRD, what do you do? So some HRD, the other caveat you also remember, since we have been listening from morning, is some HRD patients are also platinum refractory. So what is the problem? What do you do with these patients? Is the question. Now coming to people who are HRD negative but platinum sensitive, you have two drugs which are there, niraparib and rucaparib. But do we use them straight away or without any this thing? There are two things that we can do in this group of patients. One is there is something called a Kelm score, where you do the CA125 illumination constant you check. And if the score is less than 1, the overall survival is better compared to if it is more than 1 when you use PARP inhibitors in platinum sensitive. And also look at the chemotherapy response score in patients who are undergoing neoadjuvant chemotherapy. Suppose the chemotherapy response score is 3, that it means the patient has had a very excellent response. So those patients may benefit better from PARP inhibitors than a person who has had a CRS score 1. So maybe you can be a little more selective in using PARP inhibitors in platinum sensitive who are probably HRD negative, or you have not done a HRD status for various reasons. However, over a period of time, what happens is in ovarian cancers, the main problem is the platinum resistance. Now we should know what exactly is platinum resistance. There could be 3 different types of platinum resistance. One is primary refractory. These patients never respond to platinum. These patients may progress while you are treating or within 4 weeks after stopping a platinum treatment. Then you have what is called as primary resistance, where patients respond to platinum but they come back with disease within 6 months after stopping the treatment. And the most common thing is the secondary resistance. That is, patients are platinum sensitive, you use platinum repeatedly, and over a period of time they become platinum resistant. They are not inherently platinum resistant, or they don't become platinum resistant immediately, but over a period of time, after 2 lines, 3 lines, 4 lines, they eventually become platinum resistant. So what do we do for these patients? What are the options that we have? We have second line of chemotherapy, which may be the same combination like paclitaxel carboplatin if you had a good platinum free interval, or you could use alternate regimens depending on what the patient has or can afford, or what is feasible for that patient. PARP inhibitors generally are now recommended as second line or as treatment or as a maintenance therapy only in germline mutations. In patients who are HRD positive, second line or maintenance second line treatment is generally not worked very well. The other concept is the PARP resistance, which we have listened to extensively, so I will not go into the details. But what do you do if you have PARP resistance? There are several trials going on with several drugs. You have patients who can use DNA checkpoint inhibitors, one like prixasertib, adavosertib, HSP90 inhibitors called onelacib, MAP kinase inhibitors like cobimetinib, PIK3 inhibitors, alpelisib, AKT inhibitors like capivasertib. Quite a few of these drugs are actually available in the market, where you could use depending on what you find as a cause of PARP inhibitor. Like a P53 mutated tumor generally has a deficient G1S checkpoint, and they are dependent on the G2M checkpoint for the DNA damage repair. Now this V1 tyrosine kinase is a critical component of the G2M cell cycle checkpoint inhibitor, and this adavosertib prevents that, inhibits that V1 receptor, and that's how it can overcome this thing. This is one example of how you could overcome a PARP inhibitor resistance. Now, what happens to patients when they become a platinum resistant? What do you treat? How do you treat? Apart from the routine chemotherapies, you can use gemcitabine, carboplatin, you could use topotecan, liposomal doxorubicin. After that, what do you use? What problems you have? So now there are a host of new drugs that are there. Antibody drug conjugates targeting the folate receptor, mirvetuximab, and there are a lot of another 3-4 monoclonal antibodies which target the same folate receptor, but with different payloads, with different chemotherapy agents. So there is a lot of trials and lot of promising results, this thing which is coming out of it. Also, it is known that there are antibody drug conjugates like active against TROP2, which we use sacituzumab govitecan, which is used in breast cancer. TROP2 is also found on ovarian cancer cells, and that could be used. And for folate receptors, now this thing is you do an assay to find out the IHC, to find out the folate receptor. It should be high, that is about 70%, 75% positivity. But what do you do for patients who are not so high, like 25 to 75%? You can use it with bevacizumab, and I think there is a trial where they have found success when you have used mirvetuximab with bevacizumab in patients who are not very rich folate receptor, very rich this thing. Then for HER2 positive patients, you have trastuzumab deruxtecan, and there is one other molecule called CDH6, which is a IgG monoclonal antibody attached to a topoisomerase inhibitor, and they have nanoparticle drug conjugates and host of other new things that are in the pipeline coming in for platinum resistant ovarian cancer. Then we have had lot of talks about immunotherapy. We know checkpoint immunotherapy has had poor responses, immunologically cold, but checkpoint inhibitors are not the only immunological therapies that are available to treat any patient. There are so many other immunological approaches that you can do. One is all these drugs are there in the clinical trial. One is an engineered interleukin 2 called nemivaleukin alpha, and it is used in combination with pembrolizumab. There is IL-2 plasmid therapy where they implant the drugs intraperitoneally, and the IL-2 is released into the peritoneal cavity over a period of time. Then there is adoptive T cell therapy where you use TILs, CAR T cell, CAR NK cell therapy trials are going on. You have cancer vaccines in combination with chemotherapy and bevacizumab or niraparib. And there is another cancer vaccine which targets HLA-A2 positivity, and there is another gene-based vascular disrupting agent with immunotherapy properties, and it is delivered via non-replicating adenovirus. Okay, now all these things which I have talked about high-grade serous carcinoma, but they are not the only cancers. They may constitute about 70% of the ovarian cancers, but you have another 30% who are rare ovarian cancers. Now let us see at what we can do for them. Low-grade serous carcinomas generally have good prognosis. They are about 10% of the serous carcinomas. They are ERPR positive, KRAS, BRAF, PAX2 positive, and most of these patients respond to tamoxifen, letrozole or fulvestrant. Now there are clinical trials where in these low-grade serous carcinoma patients, they are trying to avoid chemotherapy using only an hormone therapy as adjuvant therapy, or you give chemotherapy and use letrozole as a maintenance therapy post chemotherapy, and they have found good results with that. And there is also trials where you have used CDK inhibitors with letrozole in a recurrent setting, and there are trials where they are using neoadjuvant fulvestrant with CDK inhibitor for abemaciclib in these low-grade serous carcinomas, avoiding chemotherapy totally. And you also have for patients who are RAS mutated, RAF and MEK kinase inhibitors like trametinib, with the focal adhesion kinase inhibitor called defactinib is used in these patients, where generally in a RAS mutated patients it is very difficult to control tumors, but with this drug they have shown promising results. Next, this thing is a clear cell carcinoma. This is an aggressive tumor, chemo resistant, has decreased survival, and this has shown several mutations, and in a few percentage of patients, say about 10-15% of patients, they are MSI high. Generally you find in about 1% or 2% of ovarian cancers who are MSI high, but in about 10 to 15% of clear cell carcinomas, they are MSI high. Worthwhile doing MSI status in clear cell carcinoma patients, and we can offer immunotherapy to these patients. There is a drug called epacadostat, which is an IDO inhibitor, and this inhibition of this improves the tumor cell response, and combination of that drug with pembrolizumab has shown responses in patients. You could add mTOR inhibitors, anti-angiogenic agents, multiple tyrosine kinase inhibitors. All these drugs have shown some responses, about 8 to 10%, not much of this thing in clear cell carcinoma. And there are some new molecules called tazemetostat, EZH2 methyltransferase inhibitors, which is generally used in hematological malignancies, has shown some response. And there are some drugs called which are RAT3 related inhibitor with PARP inhibitors which may show response. You have mucinous carcinomas, another rare type of carcinomas, rare gynecological cancers, where you use JA protocols. In these group of patients, you see HER2 amplification or mutations, so monoclonal antibodies and lapatinib could be useful. They may also express MSI high, so CPI checkpoint inhibitors may be useful. And you have some of these mucinous carcinomas have FGFR2 mutation, PIK3 mutation, PTEN mutations, for which specific TKIs are available. So it may be worthwhile in doing this rare gynecological cancers, doing genetic profiling may be helpful in trying to get some targets to treat these patients. Carcinosarcoma is another very aggressive type. In these also we have seen that they are HER2 positive and they have high PD-L1 expression, especially in the epithelial component, and you can use this IDO, this thing which helps in combination with pembrolizumab in this group of patients. So with all these things, where are we? That is the problem, because eventually most of the patients progress and they succumb to the disease. You may have at the maximum of 5 years survival for about 35-40%, even in stage 3, stage 4 cancers. So majority of the patients still progress over a period of time and succumb to the disease. So here is what I propose. We should have a cohort of about 150-200 patients of all ovarian cancer types. We should study the tumor comprehensively, longitudinally, over a period of time, okay, over the length of their survival. And we do baseline germline BRCA mutation, HRD testing, HER2 testing, MSI, DMMR, NGS, study the tumor microenvironment, look at the tumor associated antigens, gut microbiome, and the hormone receptor status, all these things. Try to identify patients who are primary refractory or primary platinum resistant. So if we can identify, we can avoid wasting time giving platinum to them and look to treat them differently. All the other patients you treat as per standard protocol, and post-treatment CA125 becomes normal, you do a CT or PET-CT imaging, no evidence of disease. But in spite of this status, most patients have recurrence. So what do you do? In patients who are BRCA or HRD positive, PARP inhibitor maintenance is always there. But that happens in only about 50% of patients. In the next 50% of patients, we don't have a maintenance. Years back, like about 30 years back, when I was training in medical oncology at Cancer Institute in Adyar, there was a concept of second look laparotomy at that point of time, where patients would have done a primary debulking surgery, would have given chemotherapy, and then you would do a second look laparotomy to see whether there is any evidence of disease or not. Okay, and if there was no evidence of disease, you would consolidate by giving an intraperitoneal therapy to those patients to improve their survival. If there is gross disease still left behind, there was nothing much we could do, because that was a period when we, other than cyclophosphamide and platinum, we had no other drugs. Paclitaxel came only in the late 90s, 96, 97. So you had no drugs. But because of the problem of having no drugs, that concept fell through. But now there is a renewed interest in this thing. Now you don't have to do a laparotomy, you do a second look diagnostic laparoscopy, especially in patients who are CA125 normal, imaging negative, but no HRD status, where you want to do something for those patients to improve the survival. Do a second look laparoscopy. Look for any evidence of minimal residual disease. Okay, you find small granules, take a biopsy of that, or do a fluid cytology, see if there are any cancer cells. At the same time, do a ctDNA, because you need to correlate and quantify the ctDNA. So you need to see whether there is a minimal residual disease in the abdominal cavity, and whether you can look for it even in the bloodstream, because you cannot keep doing diagnostic laparoscopy repeatedly. And then if you find a minimal residual disease or anything, you could treat them, like if PARP inhibitor, because they are platinum sensitive, or you could add further chemotherapy if you thought that the disease burden was a little more, or bevacizumab, or you could use metronomic therapy with a low dose immunotherapy. Now, why metronomic therapy is, we already saw that it affects the cancer cells directly and indirectly. It impedes tumor angiogenesis, it enhances immune response, and promotes tumor dormancy. Now, this concept has been tried in recurrent head and neck cancers, and there has been good progression-free survival. Maybe in a patient who has got very minimal disease burden, you could try this concept with a low-dose immunotherapy. This may give you an advantage. And you follow up these patients after treating at regular intervals, do a ctDNA, and try to see where it goes, how it goes, and at what time you could have a recurrence. So this is one point that we can always think of. And for the rest of the patients, you are following up the patients, and at each time there is a recurrence or progression, you try to repeat the biopsy, or you collect the ascitic fluid or a pleural fluid, do a cell block, or if you have no thing where you cannot collect that, you do a liquid biopsy. Again, study the same thing, do an NGS, check the tumor microenvironment, gut microbiome, and see what is the pattern, why this has happened. You continue to treat as per the patient's feasibility, both clinically and financially, and then at the end of this thing, for each patient that has gone through the process, you look at what correlates with what treatment was given, what was the response, what was the progression-free survival, and where and what did not work. And if the tumor profile gives any clue for what it works in, which scenario, and what does not work, we can look at new targets, and how to combine and sequence drugs. It would be a big help. I know it is a very fantasy sort of a thing, but it may be worthwhile thinking and planning and doing it. Maybe if you start now, in the next 5-6 years, you could have something very meaningful. That is what we have been seeing from morning. Everybody is looking at one part of the thing. Somebody is looking at chemo resistance, somebody is looking at tumor microenvironment, somebody is saying, I don't have this paired tissue, that paired tissue, and I don't get the follow-up tissues. I think doing a longitudinal study choose a cohort and follow them up till their natural history is the way to go forward. The other thing I thought was, in platinum-resistant ovarian cancers who have received already 3 or more lines of chemotherapy, we could use a VEGF inhibitor. There could still be a role of metronomic therapy with IO drugs. We could use either standard IO drugs, where if patients can afford, or with a low dose, and follow up them and see whether this could help in breaking the resistance to checkpoint inhibitors. Endometrial cancer, again, in endometrial cancer, early endometrial cancer, it was a very standard thing. Do primary surgery, adjuvant therapy, and like radiation or chemotherapy depending on the histology stage, grade, and the grade of the tumor. But now the TCGA molecular classification has actually shaken up the endometrial cancer in a big way. Now they are classifying the endometrial cancers into 4 different types: Pol E, MSI high, high copy number, and low copy number. High copy number is generally for a P53 mutated, and a low copy number is P53 wild type, and they are also called as no specific mutation potential. I'll just go through this thing for the benefits of the postgraduates. The Pol E mutation is an exonuclease domain of the DNA polymerase epsilon. It constitutes about 4 to 8% of endometrial cancers. They have extremely good prognosis, almost 98 to 100% survival. They have a high mutational burden. They are called ultra-mutated tumors. And if you look at the conventional histology and which constitutes Pol, it is a mix of everything. It could be a part of low or high-grade endometrioid carcinoma, and also some serous dedifferentiated clear cell carcinoma and carcinosarcoma. So your histology will not predict whether it is Poli or not. Then coming to the MSI or DMMR tumors, it constitutes about 20 to 40% of endometrial cancers. It is an intermediate risk group. You can do it by IHC or by gene sequencing. They have a response to immunotherapy, but they may show a possible chemoresistance. And if you look at the spectrum of endometrial cancers that we conventionally see, it could constitute high-grade endometrioid, undifferentiated clear cell, and also a group of low-grade endometrioid. Copy number high, this constitutes about 58% of the endometrial. These are the largest tumors, P53 mutated, and they generally constitute high-grade tumors like serous tumors, clear cell carcinoma, carcinosarcoma, and dedifferentiated tumors, and they are poor prognostic. And generally, these class of tumors benefit from chemotherapy and addition of bevacizumab. They are also shown that in a recurrent setting, pembrolizumab and lenvatinib may be useful in this group of patients. The last group is the copy number low. This is about 40 to 50% of tumors. They are intermediate risk, and they are shown to be hormone receptor positive, and these tumors are described to have substantial LVSI, and they come from low to high grade endometrioid, clear cell, carcinosarcoma, or dedifferentiated. So the conventional histology generally does not define unto which of these molecular types the tumor belongs. Now there's again another thing. In few of these patients they have studied especially the CTNNB1 and the L1CAM mutation, and if they are there, it indicates a poor prognosis and pushes the patient to a high intermediate risk group, and they have a distant recurrence. The L1CAM is generally seen in P53 mutated patients, and the CTNNB is generally seen in the low copy number mutations, and it pulls down this thing. The CTNNB, especially if you found in endometrioid carcinomas, low risk group, patients who don't have LVSI and who have no myometrial invasion, with all good factors, they recur, and most often than not, the culprit is the CTNNB1 mutation. So just the molecular group is not enough. There are a lot of other caveats also to those things which we can look at. So correlating the molecular classification benefit from adjuvant chemotherapy, they have done trials. They have looked at the GOG group has looked at the Pol classification in all the retrospectively and seen. And they said that the P53 has the worst prognosis but the greatest benefit from chemotherapy. The Poly has got excellent prognosis, but it does not, and generally does not relapse irrespective of whether the patient has received treatment or not treatment. And the MSI and the NSMBP group have an intermediate prognosis, but they may minimal benefit from chemotherapy. So may have to look at treating them either with checkpoint inhibitors or hormone agents rather than using chemotherapy. So actually now clinical trials are in progress. This was also averred to earlier, to tailor or de-escalate the treatment in the adjuvant setting for endometrioid carcinomas. You have the TransPortec Rainbow trial, and the Portec 4A trial, and the Taper trial, where they looked at poly mutated and NSMP subsets only. The POTEC trial looks at de-escalating the radiotherapy thing. So these trials, the results should come in the next 2-3 years, and then we could have a totally different way of treating adjuvant endometrial cancers. Now, not only this, you have to look at other markers also. Now, a fair group of patients of endometrial carcinomas are HER2 positive and hormone receptor positive, and at least about 25-30% of the P53 mutants also have HRD positivity. So you could still, those are a group of other markers that we can study. PDL1 and tumor mutation burden is another thing that has not been that has not come into being. PDL1 is high in various groups. It can be as high as 75-80% expressions. But when you have correlated checkpoint inhibitor response to PDL1 versus MSI, MSI takes the cake. So PDL1 has never been a thing where people have looked at expression of PDL1 in checkpoint to target use checkpoint inhibitors. And because of the presence of immune checkpoint inhibitors and presence of HER2 positivity, lot of people are now looking at neoadjuvant therapy before doing surgery, because even in endometrial carcinoma, getting a complete resection, R0 resection, is very important for survival. Advanced endometrial carcinomas, for MSI high or dMMR tumors, chemotherapy IO has become the standard based on the Ruby trial and the other trial, pembrolizumab and dostarlimab. Now, there are trials where they have used IO with TKI, that is venvatinib. This has been used both in the second line and after the patients have progressed on the first line chemotherapy. You have IO drugs with PARP inhibitors and IO drugs with radiation that are going on in the subsequent lines of treatment. The trials are on the way. And in MSI low or proficient MMR also, you have the same options, but they are less effective other than the routine chemotherapy. So the question that we have to ask is, in the MSI low or proficient MMR, why it works in some patients and why it doesn't work in others. So if you can look and have an insight into what really works, you may find new biomarkers which may really predict which patients may respond to immunotherapy other than the MSI status. There are a lot of other new drugs, new things that also have come in endometrial cancer in the subsequent lines. You have anti-drug conjugates like HER2, you have trastuzumab deruxtecan, folate receptor, mirvetuximab sotorastat is effective in folate receptors are expressed even on endometrial cancers. You have TROP2 expression, so sacituzumab govitecan can be used, and there is this CDH6 molecule which can be targeted. And in hormone receptive patients, you have an option of using tamoxifen alternating with megestrol and letrozole with everolimus, and this has shown to be effective in patients who have that CCNTB mutation in low-grade endometrial carcinomas who are otherwise good risk. And letrozole plus CDK inhibitors is another option that you can explore. And in NSMBP tumors, there are trials which they are using MDM2 inhibitors and selenoxib, which is a selective inhibitor of nuclear exporter, the XPO1. And actually this drug is in use in multiple myeloma. So they have used these drugs in NSMBP tumors where you have very few targets that you can look at. So I think even in recurrent endometrial cancer, a comprehensive tumor profiling to look for potential targets for treatment or to identify profiles which suggest a response or refractoriness to a particular treatment is important. Though we have more options, less problematic than to treat ovarian cancer, some endometrial cancers are very difficult to treat and they progress very rapidly and this thing. So these are things that we can look into in our future. This thing. Thank you.
Sir, thank you for a very comprehensive talk. I think you kind of summarized the whole day's thoughts and everything that we have been talking about. You even gave a roadmap to how we should go forward. But I have a question, sir. Because you in your practice, I think, have seen very large number of cases, and you know the real challenges. Is there one test that we have today that you would go by no matter what, that absolutely has to be done? And what is the one test that is your dream marker that you would like to have for all cancers? I know you gave a very comprehensive roadmap, but we would like to know.
I think one test if I would want to do for any this thing is I would do an NGS test. Next generation.
You mean a
sequencing.
comprehensive like
Next
500?
Yeah. I think at least that will give us a basic idea as to what we are standing, and it may give us an idea as to whether we have a target or not, or it may give us an idea as to whether somebody is going to respond to a particular treatment or not. And if you have a cluster of that patients, you may over a period of time learn how to treat, how to target this thing. So if you want to ask me one test, it would probably cover the entire gamut of gynec
With
cancers.
this, would you think a liquid biopsy along with the tumor for a primary tumor would help, sir?
Yeah.
To serially follow?
Yeah, I think so. We should do, actually, in all cancers, it is coming into vogue that both liquid biopsy and tissue biopsy, both are complementary, not to the exclusion of each other. There are some things which you can get from this, which you cannot get in liquid biopsy. What you get in a liquid biopsy, you may not get in a tumor tissue.
Yes, people have argued that liquid biopsies are more representative of the
because of the tumor heterogeneity.
But just that in the ovarian cancer landscape, mutational burden is quite low. So that is where my question is, in this tumor, would that help?
Yeah, I think we have seen, actually it's not only the tumor that is the problem in ovarian cancer, it's the tumor microenvironment which is the problem, or which may be a major problem. And it's a major problem basically because it may not allow your treatment to work, the tumor microenvironment.
That's
So,
what we learned
yeah,
today.
that is what is the lesson. So you may have effective medicines, but the tumor microenvironment is not working. Actually, I think Dr. Asimo also referred to that, and there is this thing when I was going through this, I learned about it also. And there was a beautiful depiction of how tumor on a diaphragmatic surface could look, where you could have a plaque-like tumor, or you could have like tumor nodule-like, and the plaque-like tumor was very infiltrative. You could not dissect it out, you could not clear it out, whereas the globular, nodular types, you could easily scrape it out. And when they have done an NGS analysis on that, they have found different profiling, tumor profiling in both the scenarios. I think I can share this thing with you. So something very amazing. So it is, I think, what the tumor microenvironment is more important than medicine. It is something like when you treat hepatocellular carcinomas, it is not the tumor as such, it is the remaining liver. How much of the functioning remaining liver you have is more important than what you can do for the tumor.
Yes, sir. I think the challenge is, like you rightly said, 50% could have HRD in many ways, wherever it is stemming from. But regardless of that, everybody is given platinum, and we see that about 70% have recurrences. So
That's what platinum resistance is one big thing, and we use lot of generics, and again generics, you are never sure about the drug. I think there is lot of things you could do with whether what is the drug contained, how this thing it is, genuine it is needs to be checked. I mean, there could be a problem because of this thing. The other thing is compliance, we don't know. We trust our patients that they take, but a lot of people may not take because of the side effects of the medicine, and the problems, and of course the money that is involved. So there are a lot of issues that need to be thought of also, but PARP resistance is a genuine thing. We have seen, at least I can remember 2-3 patients who are BRCA1 positive, whom we have used, they not even responded for 2 months, 3 months. They have come back with disease. So I think there are areas where you can look. A lot of things are learned where, as I've said earlier in earlier things also, before we look at comprehensively a follow-up cohort, we can always study patients who do extremely well and patients who don't do extremely well, who do very badly. So if you study these two tumor characteristics, you may have lot to learn from these patients.
Thank you, sir. Really comprehensive. Any other questions for sir?
Thank you.